Well, hello and welcome to my diagnosis series. In this segment, I'm going to be discussing forensic psychology and the quasi-judicial role that they've developed for themselves in the family courts. And to begin with, I'll be discussing sort of the background history of family custody conflict and the origins of forensic psychology in the family courts, and then ultimately discuss the return of clinical psychology to court-involved custody conflict. So to begin with, um, an important aspect to understand about high conflict custody litigation from clinical psychology is that high conflict custody litigation indicates the presence of a high conflict personality pathology in a parent. So let me just stop that and just say a little bit about that, which is no normal range parent puts their child through a high conflict custody battle in the family courts, because all normal range parents have empathy for the child and realize the destructive impact that would have on the child. And so normal range parents find a way to work things out and work together. The fact that we have high conflict that's in a high conflict custody litigation means we have at least one parent who's absent of empathy, and that would be a narcissistic, borderline, or a dark personality parent. So the presence, just the mere presence of high conflict custody litigation in the family courts would indicate either a narcissistic personality pathology, and that pathology is vulnerable to rejection, which is the divorce. It creates a narcissistic injury and a desire for revenge. The narcissistic and dark personalities are highly vengeful. And the narcissistic personality, when they have a narcissistic injury, needs to self stabilize. So they will incorporate the child in as a regulatory object to counter the narrative with, I'm not the rejected one, you are, the child is rejecting you. The second variant of the pathology in the family courts is from a borderline personality. And these are vulnerable to abandonment fears, which are triggered by the divorce. And they have free floating fears from unresolved trauma that get displaced into the current situation. So you get high false allegations and high anxiety with that variant. And basically, though, what we're looking at in terms of personality pathology, I wouldn't get too hung up on the diagnostic categories. What we're looking at is research identified personality pathologies of the dark triad, vulnerable dark triad, and dark tetrad. And these are some clinical constellations of personality pathology that have been identified in the research literature. The dark triad is narcissistic pathology, psychopathic pathology, and Machiavellian levels of manipulation. The vulnerable dark triad is vulnerable narcissism, type 2 psychopathy, which is highly manipulative, and borderline personality pathology. And if we add sadism to the dark triad, we get the dark tetrad. So these are the personality pathologies that we're worried about in the family courts, creating the high conflict custody litigation. And the narcissistic borderline dark personality parent creates a false pathology in the child for secondary gain to that parent. The potential secondary gain include manipulating the court. So they're creating this pathology in the child to manipulate the court's decisions regarding child custody. And for spousal abuse, so the targeted parent to emotionally and psychologically abuse the ex-spouse parent using the child and the child's induced pathology as a spousal abuse weapon. And then the pathological parent, allied parent, uses the child as a regulatory object to meet the parent's own emotional and psychological needs. So the dark personality, the narcissistic borderline dark personality parent, drives the child's induced pathology into the wrong system for the solution. A child rejecting a parent is a pathology and should be in the healthcare system for diagnosis and treatment. It's not a crime and is in the wrong system when it's in the legal system. But they make it about custody rather than treatment and drive it into the wrong system. So the narcissistic borderline dark personality parent drives the pathology into the adversarial legal system because they can manipulate the legal system to fight about the problem rather than diagnosing and treating it. And they don't want it treated. They don't want it to go away. They want the pathology and they want to use it and exploit it, which is why they create it and then drive it into the family courts to exploit it, to manipulate the court. The allied parent is seeking to put the ex-spouse on trial for being a bad parent, a bad spouse. So that's the important framework to understand from a clinical psychology perspective about the nature of high conflict custody litigation. We are very, very likely looking at least one parent with narcissistic borderline and dark personality traits who's collapsing from the narcissistic injury or from the abandonment fears. In this situation, we might have sadistic qualities involved. We have spousal abuse concerns, using the child as a weapon. We have child psychological abuse concerns, creating false pathology in the child for secondary gain to the parent. And they're doing this to stabilize their own collapsing emotional structure surrounding the inherent rejection and inherent abandonment associated with divorce. So the history of custody conflict in the family courts involves staff splitting, and that's the origins of forensic psychology in the family courts. That the increased frequency of divorce in the 1980s generated high conflict custody cases from narcissistic borderline dark parental personality pathology. So normal range parents are able to get through this just fine, but the narcissistic borderline dark personality creates conflict and drives it into the legal system to exploit the child's pathology and manipulate the courts. And what happened was a parallel process in the psychologists, so that the splitting symptom, which is a symptom of polarization into extremes, into sides with no middle. So the splitting symptom of the parent's narcissistic borderline dark personality pathology triggered a parallel process of staff splitting in the professional psychologists. And the professionals wound up taking sides in the adversarial legal system. And here's a description of staff splitting from Marsha Linehan. Staff splitting is characteristic of borderline personality pathology. And as you know, staff splitting, as mentioned earlier, is a much discussed phenomenon in which professionals treating borderline patients begin arguing and fighting about a patient, the treatment plan, or the behavior of the other professionals with the patient. So that's what happened in the 1980s. Professional psychology was new to encountering divorce and new to encountering high conflict divorce and custody conflicts. And as it encountered the high conflict custody litigations and the narcissistic borderline dark personalities who are highly manipulative, the pathological parent would manipulate some of the involved mental health professionals to be on their side against the other parent, and we had sides develop in the psychologists that were parallel to the sides in the pathology of the two parents. So everything was a mess, and we just had competing experts on the situation. So the effort of professional psychology to resolve that was an effort to contain the parallel process of staff splitting in the family courts, the professionals taking sides. And so the forensic psychologists were allowed to simply make up an experimental new approach to mental health service delivery. a new quasi-judicial role for doctors of making custody decisions. The forensic psychologist then created a new assessment approach that also never existed before, a forensic custody evaluation for their new made-up quasi-judicial role. And what's important to understand is that forensic custody evaluations are an experiment on children and parents in the family courts, and that the experiment failed. And so that aspect of the situation, there has been no history of this thing called forensic custody evaluations or a quasi-judicial role for doctors. Throughout all of healthcare, throughout all of history, this is a new experimental approach on children and parents in the family courts. And so to understand, or as we look at what they did, this experimental new approach, I will be citing two books by Stahl and Simon and Stahl, second edition. The Forensic Psychology Consultation in Child Custody Litigation, a handbook for work product review, case preparation, and expert testimony, published by the American Bar Association, and then the second edition in 2020. So, regarding the guidelines for this new experimental approach, a quasi-judicial role for doctors did not exist prior to the 1980s. The first guidelines for this experimental new approach were provided in the mid-1990s, and here's from Stahl and Simon in 2013. Not until 1994 did the American Psychological Association recognize the importance of formalizing guidelines for child custody evaluations by publishing its first set of child custody evaluation guidelines. So here's to the guidelines here, just to be clear on what guidelines are from the American Psychological Association, from their guidelines on custody evaluations. Guidelines are aspirational in intent. They are intended to facilitate the continued systematic development of the profession and to help facilitate a high level of practice by psychologists. Guidelines are not intended to be mandatory or exhaustive and may not be applicable into every professional situation. They are not definitive, and they are not intended to take precedence over the judgment of psychologists. So they're really like nothing, okay? They're aspirational in intent, and that the judgment of psychologists is supposed to supersede whatever guidelines are involved, and they're given any given specific situation. So the guidelines even are not formal, really. They're just suggested things. Don't be biased, and make sure you're fair to everybody and accurate and objective. The forensic psychologist, now the difficulty with coming up with an experimental approach is that the forensic psychologist never informed the parents or the courts that a quasi-judicial role for doctors and their new forensic custody evaluation assessment approach are an experiment on children and parents in the family courts. The courts and the parents thought this was a professional level activity, and it's not. It's just a made-up thing that a bunch of people with degrees decided to do. And even more troubling to me is that the forensic psychologists never offered parents or the courts the alternative available from standard clinical care, diagnosis, and treatment, which they should have done in an experimental procedure. You give the people the choice of the experimental procedure and standard of care. They didn't offer the standard of care, and they forced everybody to do their experimental approach that has no research or scientific basis to it. So they gave parents and the courts only one alternative, their experimental new approach. So, as an experimental field, Saul and Simon in 2013 described As a formal and organized field, forensic psychology has entered its adolescence but is far from mature. This illustrates the reality that as an organized field and an organized systematic approach to behavioral science, forensic psychology remains in its formative years. Now, from 2020, their second edition. As a formal and organized field, forensic psychology has entered its adolescence but is far from mature. This illustrates the reality that as an organized field and an organized systematic approach to behavioral sciences, forensic psychology remains in its formative years. So, first off, to note, between 2013 and 2020, the forensic psychologists, by their own admission, have made zero progress in developing this new experiment of theirs. Okay, so it's still in its adolescence after 30 years. It's still in its formative phase after 30 years, and it doesn't look like it's ever going to reach any sort of conclusion on that because it's an awful approach. The experimental approach of forensic custody evaluations remains a truly new field that is far from mature and remains in its formative years after 30 years, 1994 to 2024. Clinical psychology, by contrast, diagnosis and treatment, is an established field that is fully mature and fully formed. Forensic psychologists left the field of established healthcare practices, diagnosis and treatment, and made up a new experimental quasi-judicial role for themselves that does not exist anywhere in established healthcare. From Stahl and Simon, 2013, because forensic psychology is truly a new field, many child custody evaluators, having been trained only in the clinical tradition, bring to their work what we call a clinical mindset rather than a forensic mindset. Diagnosis and treatment is a clinical mindset. Clinical thinking and the clinical mindset are no longer thought to be appropriate approach to forensic psychological work. The forensic psychologists left the field of healthcare to develop a new role, this new quasi-experimental role. So in terms of their statement that clinical thinking and clinical mindset are no longer thought by them to be appropriate approach to forensic psychological work, I disagree. Forensic psychology in the family courts is a failed experiment, and clinical psychology, diagnosis and treatment needs to return to court-involved custody conflict. And I'm willing to debate this anytime, anywhere with anyone. Let's put together a formal 2-hour online moderated debate. The role of forensic and clinical psychology in the family courts. I'll represent for clinical psychology. Find any forensic psychologist you want who is willing to defend what they do. The AFCC, to talk about how they left the field of healthcare and left the field of clinical psychology to do something different, this quasi-judicial role. This is from the Association of Family and Conciliation Courts, a professional organization for the family courts, the AFCC. And in their model standards for custody evaluations, the AFCC encourages the forensic psychologist to withhold the diagnostic information from the court. So here's what they say under Standard 4.6, presentation of findings and opinions. Presentation. So this is a presentation to the court and to the parent litigants. Evaluators recognize that the use of diagnostic labels, okay, so I'm going to stop there. It's not a diagnostic label, it's a diagnosis. So the diagnostic label of schizophrenia is a diagnosis of schizophrenia. The diagnostic label of autism is a diagnosis of autism. They're using the word label to make diagnosis seem something unusual or harmful. It's a diagnostic label. We don't like to label people. No, diagnosis is identifying what the problem is. If someone has schizophrenia, we want to say, use the diagnostic label that that person has schizophrenia because that's the person's diagnosis. Autism, ADHD, an eating disorder, a shared delusional disorder, factitious disorder imposed on another, child psychological abuse, all of those are diagnostic labels. So they're saying they uh, recognize that the use of diagnostic labels such as child abuse, spousal abuse, delusional thought disorders, and factitious disorders imposed on the child, that those diagnostic labels can divert attention from the focus of the evaluation. So let me pull that back. So it's clear the focus of their evaluation is not to identify whether there's a possible persecutory delusion in the family. That's a diagnostic label that is diverting focus away from the purpose of their evaluation to identify that it's a persecutory delusion, or identify that it's a factitious disorder imposed on another, or to identify the diagnostic label of child psychological abuse, or to identify the diagnostic label of spousal psychological abuse using the child as a weapon. So they say all of those diagnostic labels divert focus away from the true purpose of the evaluation, which is namely the functional abilities of the litigants whose disputes are before the court. So the forensic psychologists are colluding in covering up the pathology of the allied parent, the pathological parent, by withholding diagnostic information about shared delusional disorders, factitious disorders, child abuse, and spousal abuse, because those are diagnostic labels. And we're talking about some sort of indescript functional abilities. Okay. So I would argue that they are covering up the child abuse and spousal abuse in the family courts and practicing substantially below the levels of clinical psychology. So and that such labels are often more prejudicial than probative. For these reasons, evaluators should give careful consideration to the inclusion of diagnostic labels in their report. In evaluating a litigant where significant deficiencies are noted, notice deficiencies. The person has a delusional thought disorder. That's not a deficiency, that's a pathology. The person has factitious disorder imposed on another. They are imposing a false pathology on the child. That is not a deficiency. That is child psychological abuse. They are using the child as a spousal abuse weapon against the targeted parent. That's not a deficiency. That's spousal abuse. So they're covering up the abuse and pathology of the pathological parent by using these euphemisms and vague terms rather than applying the diagnostic system of the American Psychiatric Association. For these reasons, evaluation should give careful consideration in their evaluating a litigant where significant deficiencies are noted. Evaluators shall specify the manner in which the noted deficiencies bear on the issues before the court. So they are taking whatever the court's decisions are and intruding into the court's decision. That's all the court's decisions. They are intruding in to try to adapt the information to manipulate the court's decisions on what's. That's not the role of doctors. Doctors diagnose and treat pathology. The doctor doing the assessment should diagnose what the pathology is using established diagnostic systems and should inform the court fully about what the diagnosis, any relevant diagnoses in the family, and allow the court to apply whatever decision-making criteria it then applies to the evidence. There is no quasi-judicial role for doctors. That is an experimental role, and it's a wrong, misguided role for doctors. The AFCC instructs forensic custody evaluators to withhold formal diagnostic information from the court's consideration and from the awareness of the litigant parents, because professional level information about the nature of a parent's pathology may be prejudicial to the pathological parent in their custody conflict with the other parent. What's important to note is that what is prejudicial to one litigant parent is of probative value to the other litigant parent. So one of those litigant parents wants that diagnosis made, wants that court informed that the other parent has a delusional thought disorder that they're creating in the child, a shared persecutor delusion. The targeted parent wants the court to know that the child has a factitious, false attachment pathology being imposed on the child by the pathological parenting of the allied parent. The targeted parent wants the court to know, and it is highly probative, that the child is being psychologically abused by the allied parent, and that the targeted parent is being spousally abused using the child as a weapon. All of those are highly probative to the case of the targeted parent and prejudicial to the case of the allied pathological parent. Okay. By making a decision about withholding information that could be prejudicial to the pathological parent, they are withholding that information from the targeted parent and the attorney of the targeted parent so that they cannot make their full case and argue their full case to the court for child protection, because none of this information is being given to the litigant parent or to the court. The forensic psychologists are withholding, intentionally withholding, relevant diagnostic information from the court's consideration and from one of the litigants who needs that information and wants that information in order to take a protective response for their child and a self-protective response relative to the child abuse. And that information is not being given to the parents. Doctors should not be making decisions on the relative probative or prejudicial impact of diagnoses. Doctors should not withhold relevant diagnostic information from the court and the litigant parents. What may be prejudicial to one parent litigant may be of probative value to the other parent litigant in the custody conflict. This is not the doctor's decision. The diagnostic labels of concern are a delusional disorder, a factitious disorder imposed on another, child psychological abuse, and spousal abuse of the targeted parent by the allied parent using the child as a weapon. Those are all extremely relevant diagnoses for the court's understanding and consideration in making its custody decisions. The forensic psychologists have a personal belief that their quasi-judicial role for doctors is superior to standard healthcare approach of diagnosis and treatment. This is a false belief. From the New York Blue Ribbon Commission on Forensic Custody Evaluations, forensic custody evaluators produced defective reports with potentially disastrous consequences for parents and children. From the New York Blue Ribbon Commission, in their analysis, evaluators may rely on principles and methodologies of dubious validity. In some custody cases, because of a lack of evidence or inability of parties to pay for expensive challenges of an evaluation, defective reports can thus escape meaningful scrutiny and are often accepted by the courts with potentially disastrous consequences for parents and children. They experimented on children and parents, and their experiment failed. By an 11-9 margin, a majority of the commission members favor elimination of forensic custody evaluations entirely, arguing that these reports are biased and harmful to children and lack scientific or legal value. At worst, evaluations can be dangerous, particularly in situations of domestic violence or child abuse. This is from an independent review conducted by the New York Blue Ribbon Commission on Forensic Custody Evaluations. They voted 11-9 to eliminate them entirely for being lacking scientific and legal value, being harmful to children, and being dangerous. Forensic custody evaluations are a failed experiment. One of the primary difficulties with them is it is hard, extremely hard, to challenge them. Throughout healthcare, the appellate system for a disputed diagnosis is second opinion. This is not possible with the experimental approach of forensic custody evaluations, which are extremely difficult to challenge. From Stahl and Simon, the evaluator's recommendations have a tremendous influence with the court. Overcoming the evaluator's recommendations is a daunting, complex, and expensive task. So forensic custody evaluators frequently take 6 to 9 months to conduct their evaluation for between $20,000 to $40,000. That is not replicable, and there's no way to get a second opinion on it because they don't offer a diagnosis. A clinical diagnostic assessment can be rendered within 4 to 6 weeks with a diagnosis with an active second opinion on that assessment. The forensic custody evaluators allow child and parent suffering to continue. Forensic custody evaluations do not have the goal of relieving the emotional and psychological suffering of the child or parent. From Simon and Stahl in 2020. The forensic role is a non-helper role. The evaluating forensic mental health professional is not involved in services that have as the goal the alleviation of suffering or discomfort. They don't even try to relieve the child's suffering. That's not their role. They do something different. They're not doctors who diagnose and treat pathology. They have a quasi-judicial role of informing the court what the child's custody should be. That is an inappropriate role. It's a failed role. Doctors should always help people. We do no harm. We should always have the goal of alleviating suffering in a child and in the parent. The forensic psychologists made up a new quasi-judicial role for doctors as agents of the state. When the court appoints a mental health professional to conduct a child custody evaluation and offer advisory recommendations to the court regarding the child's psychological best interests of the children, the evaluator is, in reality, an agent of the state. There is no quasi-judicial role for doctors. Doctors diagnose and treat pathology. Judges decide on custody. Forensic psychology represents a failed experiment in service delivery to a vulnerable population. Forensic custody evaluations need to be entirely eliminated from the family courts, and clinical psychology, diagnosis and treatment, needs to return to court-involved custody conflict. So, beginning with ethical standards, Standard 2.04 of the APA Ethics Code requires, mandatory, that psychologists' work is based on established scientific and professional knowledge of the discipline. The DSM-5 diagnostic system of the American Psychiatric Association is among the established scientific and professional knowledge required for application as a basis for professional judgments. All mental health professionals have duty to protect obligations. There are 3 dangerous pathologies: suicide, homicide, and abuse, child abuse, spousal abuse, and elder abuse. Whenever a mental health professional encounters a dangerous pathology, duty to protect obligations are active. From Wikipedia, duty to protect. In medical law and medical ethics, the duty to protect is the responsibility of a mental health professional to protect patients and others from foreseeable harm. Forensic psychologists are failing in their duty to protect the child from child abuse and the targeted parent from spousal abuse. Those are your differential diagnoses. The only cause of a child seeking to flee a parent, a child rejecting a parent, is child abuse by one parent or the other. And so either it's the targeted parents abusing the child, and we might have physical, sexual, neglect, or psychological abuse that's creating the child's rejection of that parent, in which case we have child abuse, or it's a false attachment pathology, and we have a delusional disorder, shared persecutory type, a factitious attachment pathology imposed on the child for secondary gain to the allied parent, psychological child abuse by the allied parent who's creating the delusional disorder and false attachment pathology in the child, and spousal or partner abuse, psychological, of the targeted parent using the child and the child's induced pathology as a weapon. So one way or the other, it's the child's symptoms are caused by child abuse by one parent or the other. And so all of these forensic custody evaluators should be returning a child abuse diagnosis simply based on the child's symptoms indicating that there's abusive parenting. But they're not on any of them because they don't use diagnostic labels. They don't assess for the differential diagnoses of concern. That forensic psychologists are failing in their duty to protect obligations on two counts. They're failing to protect the child from child abuse and failing to protect the targeted parent from spousal abuse using the child as a weapon. They have two duty to protect obligations, and they are failing in both of them. Negligence. The failure to conduct a proper risk assessment for a dangerous pathology when the assessment is warranted by the symptoms and context may represent negligent malpractice. From Cornell Law School, definition of negligence. Negligence is a failure to behave with the level of care that someone of ordinary prudence would have exercised under the same circumstances, another doctor. The behavior usually consists of actions, but can also consist of omissions when there is some duty to act. So this is potential child abuse, potential spousal abuse. All mental health professionals, their duty to protect obligations are active when they encounter court-involved custody conflict. There might be child abuse and might be spousal abuse. They are obligated to conduct a proper risk assessment, to take affirmative protective action, and to document in the medical record or to the court's understanding the protective action they took relative to the danger involved. And so the failure to do that may likely be negligent malpractice. In the appellate system in healthcare, for a disputed diagnosis is second opinion. Any diagnosis returned into the adversarial legal system of the family courts will be a disputed diagnosis. So a clinical psychology solution to that would be you have two litigants, each alleging some form of child abuse by the other. We need to get a clinical diagnostic assessment of which parent is abusing the child. It's going to be a disputed diagnosis, so each litigant should be allowed to appoint a second opinion to participate in that clinical diagnostic assessment through telehealth. That'll get us 3 doctors, maybe 2, but at least a second opinion, potentially a third opinion on the clinical diagnostic assessment. That's how we improve our diagnosis and reach an accurate diagnosis. And let me say something about diagnosis and child abuse. When possible child abuse is a considered diagnosis, our diagnosis needs to be accurate 100% of the time because misdiagnosing child abuse is too devastating to the child. And the danger with this particular pathology, a shared persecutory delusion, is that if you believe the shared delusion, you become part of the shared delusion. You become part of the pathology. And when that pathology is a psychological abuse of the child, you become part of the child abuse. When it's the spousal abuse of the targeted parent using the child as a weapon, you become part of the child abuse. So you, the mental health professional, become a child abuser and spousal abuser because you have misdiagnosed the pathology. We need to get this right. Okay? And the way we do that in healthcare is to get a second opinion, maybe even a third opinion on the diagnosis. And that's how we will improve the diagnosis. Then that improved diagnosis goes back into the court's decision making and then moves into the treatment plan to fix things. This is from the National Academy of Sciences, Engineering, and Medicine in their paper, Improving Diagnosis in Healthcare. Clinicians may refer to or consult with other clinicians, formally or informally, to seek additional expertise about a patient's health problem. The consult may help to confirm or reject the working diagnosis or may provide information on potential treatment options. Clinicians can also recommend that the patient seek a second opinion from another clinician to verify their impressions of an uncertain diagnosis, or if they believe this would be helpful to the patient. So that is what we do in healthcare. All the time. You go in with a physician, you got a physical pain, they send you out to get a second opinion from a specialist. And we can do that with telehealth. And we can do that on a clinical diagnostic assessment. We can't do that on a 6 to 9 month custody evaluation. Forensic custody evaluations are a failed experiment, and clinical psychology diagnosis and treatment needs to return to court-involved practice. In all cases of court-involved custody conflict involving severe attachment pathology displayed by the child, i.e., a child rejecting a parent, a proper risk assessment for child abuse needs to be conducted to the appropriate differential diagnoses for each parent. And so that will conclude my seminar here on the quasi-judicial role for doctors. There is no quasi-judicial role for doctors. It was an experiment. The experiment failed miserably. And as a result of their failed experiment, the lives of thousands and thousands of children and parents were irrevocably destroyed. We need to end this experimental approach of forensic custody evaluations and return to clinical diagnostic assessments in the family courts.